Any questions from any material from this morning? No. So what I'll probably end up doing is whatever I don't get through today, because we have one more class session until the test, right? They're coming fast and furious. I'll do an extra video of the rest of the content, put it up, and that way the next time we meet, it'll be a review. We'll do a Kahoot style thing. Have you guys ever used that? It's pretty cool. Basically, I will make a quiz online. You guys will log in from your computers or your phones, and then you can all sign into it, and then we'll take the quiz together. And that way, you guys can kind of see where maybe some weaknesses are. We'll talk about the questions, kind of get an idea for what the test might be like, and kind of go from there. Does that work? Yeah, it's usually a little bit shorter session, but it's kind of nice. You know, a little friendly competition between you and your classmates. It's always a good thing, right? Yes. Absolutely, you may close those doors. Yeah, those people are so rude. Please close the doors. Yeah, so that's what I'm going to be doing. It's a little bit extra video watching for you guys, actually, but please make sure to watch the video prior to coming to that review, because otherwise you're going to be missing out on some the critical information. Okay. Hopefully, people tend to like that, so that's the kind of the format I'm going to go with for now, unless you guys decide to revolt and throw me out the window. So, all right, so we're going to continue on with our talk of the thyroid. So this is the kind of general process we see occurring with production. We mentioned tyrosine being one of the kind of the precursors for thyroid hormone. This gets acted on by this peroxidase enzyme, and then you end up with either one of two products, either monoiodotyrosine or the diiodotyrosine. This is where iodine gets involved with it. At this point, these two can combine in a couple of different formats. If you have two of these diiodotyrosines, you have a molecule with 4 iodines on it, which makes T4. Yeah, absolutely. So T4 is basically where you have 2 of these diiodotyrosines put together. And you can see that this molecule right here. So this is T4 thyroxine. When we give you Synthroid for hypothyroidism, this is what we're giving you essentially. You can have 1 diiodotyrosine plus 1 monoiodotyrosine, and that will give you hopefully T3, which is the active form, right? So you're going to be mostly getting T3, but then you also have this reverse T3 as well. We mentioned what's special about reverse T3. Yeah, it's inactive. It doesn't really do a whole lot for us, right? So some small amount of our T3 will be made, but we don't really care about this so much. The actual T3, the triiodotyrosine, this is what we're interested in. This is the physically active molecule that is actually causing the metabolic effects that we care about, right? And so some of the lab tests you can do to kind of monitor a person's thyroid function is things like look at their TSH levels, right? So in this case, looking at the hypothalamus releasing thyrotropin releasing hormone, and then the anterior pituitary releasing thyroid stimulating hormone. If you have a high TSH, what is that usually indicative of? You have extra T3 or too little T3? Probably have too little, right? Because if you think about it, if you have enough T3 and T4, that should cause a negative feedback loop, and you should see a decrease in the amount of TSH, okay? You could probably also measure your TRH as well, and that would probably be high additionally, right? And so we'll look at some conditions where that might not be the case. But in general, if you have a high TSH, that usually is indicative of someone who has hypothyroidism, because they don't have that negative feedback loop being initiated there. You can also look for things like, you know, in a lot of cases you see these hormones that are being bound up by serum proteins as they go through the bloodstream. And one good thing to note for both pharmacology and for physiology is that things that are bound to serum proteins are not physiologically active, right? There's going to be some bit of an equilibrium between the free hormone and what's bound to serum proteins. The free portion of it, though, is what's active, right? That's what's able to interact with different tissue receptors and things like that. Same thing goes for drugs. If drugs are bound up to serum proteins, they're not physiologically active. So it's important to look and see, like, if you look at a free T4, that shows you the exact, it takes away kind of the proportion of it that's bound to serum proteins. It shows you what's actually physiologically active. And so you can measure a regular T4, but in some cases it's more accurate to measure a free T4 for your patients. That'll give you a better idea of how much actual active thyroid hormone they have actually floating around, okay? So this is some like kind of the big lab tests you'll do in order to determine someone's kind of thyroid function, right? So some of the things we can see with high levels of T4, right? So if we have hyperthyroidism, we're expected to see things like increased metabolic activity. What does your weight normally do if you're hyperthyroid? Yeah, it typically goes down because your metabolic rate's up. You're going to be metabolizing more carbohydrates and fats, and you're going to have increased protein synthesis, all kinds of good stuff. Stimulates growth in children, so it's important to make sure we have good stimulation there. You also end up seeing some GI changes, increased GI motility, so things like diarrhea can be seen when you're hyperthyroid, your nervous system takes a hit as well. So this is where you can get very kind of hyperstimulated. You're nervous. You have a lot of anxiety. You're worrying a lot, just because your sympathetic nervous system is just kind of ramped up through this extra thyroid hormone around. You also see things like fine muscle tremors and whatnot. And if this kind of goes along too far, do you guys know what it's called when you have like really severe hyperthyroidism? Yeah, so thyrotoxicosis certainly is a term for it. It's like the kind of even farther than that. Not really what I'm talking about. It's like thyroid. It's not. Yeah, it's not sprinkle. It's a storm. Yeah, so thyroid storm is what you might see like in the ER. Someone's having like an acute thyrotoxicosis, where they come in, they're very tachycardic, they're hypertensive, they're very anxious, and we can give medications to actually help to combat that. But yeah, so thyroid storm is one of those things we'd be looking for like in the ER kind of setting. Certainly, there are much more mild variations you may see before that. You can also see things like increased respiration, higher just metabolic activity in general. Typically, they're very hot, right? So you get kind of increased thermal regulation there. Usually, you're not going to get a whole lot of sleep. They may kind of have some insomnia there, and then also have some issues with the menstrual cycle. So you may see some irregular bleeding associated with that as well. Okay. As you mentioned, Graves' disease. What is Graves' disease? It's hyperthyroidism. Is there any particular cause for it? You don't necessarily see goiter with hyperthyroidism necessarily. Not all the time. Depends. Usually you're going to see if you have like a hypothyroidism where you're actually lacking iodine, is where you can see a lot of that goiter actually develop, at least in like developing countries and things like that. Yeah, it's usually an autoimmune condition where basically you have these antibodies which are kind of working similar to thyroid hormone, and so you can end up seeing, or looking similar like TSH, you end up generating too much thyroid hormone. But this is where you can see this exophthalmos, so they kind of have that kind of bug eye kind of look, right? So increased heart rate, reflexes, all this kind of stuff. And so it's going to be one of those kind of classic signs for hyperthyroidism that we can deal with. The big thing to note here is that you can have primary issues, you can have kind of secondary issues, and then these kind of tertiary issues, depending on which kind of aberration you have and which organ specifically. For instance, if I end up having a case where maybe I have too much iodine around, maybe I'm producing too much thyroid hormone from that standpoint. So in this case, I might measure something like my T4 and T3, and those levels would be high. But if I went back and measured my TSH or TRH, that could actually end up being low, right? Because that would be that negative feedback loop being activated, and that would make sense, right? So that'd be one case where you could see hyperthyroidism. You could have other cases though, where, for instance, you could have an anterior pituitary abnormality. Let's say you had some kind of like TSH stimulating tumor or something. You would end up finding your TSH level be high. You would also end up having a high T4 and T3, and then if you actually measure that TRH, because that is still being affected by that negative feedback loop, that would actually end up being low. Okay. Again, looking at your lab values, you can actually go back and see, like, okay, what's the primary problem that's happening here? Is it my hypothalamus? Is it the pituitary gland? Is it the thyroid gland? What's actually going on here? And something like if you had the hypothalamus being abnormal, you notice that all of these would be high because the negative feedback loop is kind of non-existent at that point, and the hypothalamus is really driving all of this hyperthyroidism. Okay, so again, going back and looking at your labs, tell what's going on. Does that make sense? On the other hand, you can have low levels of T4, so you have hypothyroidism. Again, this is basically the exact opposite of what the hyperthyroidism would look like. We're going to have decreased metabolism, decreased temperature, usually some cold insensitivities to that. Usually their mental status is kind of just depressed, and they're kind of lethargic, and kind of like you guys feel probably after my lectures, right? A little bit. But other things you can see, decreased heart rate, is hypersomnolence. It could be sleeping quite a bit. Also you can have some increased bleeding. So again, some abnormalities in the menstrual cycle there. Decreased libido, impotence can all come about from that. Actually do the same thing here as well and look to see, like, well, do we have a thyroid problem? Do we have an anterior pituitary problem or a hypothalamus problem? I mentioned that having too much iodine around can cause hyperthyroidism, but having even more iodine around can actually shut down thyroid hormone production as well. So you can actually have too much iodine, and this could cause low levels of T4 and T3. And in this case, because you're not producing enough T4 and T3 to cause this negative feedback loop, you would have high TSH and high TRH levels. Okay, because again, this negative feedback loop is not being activated. If you had a problem where the anterior pituitary gland was not functioning well, so I mentioned like those kids with their pituitary gland having been removed. In this case, they would obviously have low TSH because they don't have any pituitary gland to actually produce any TSH. Their TRH would be high though, right? Because their hypothalamus would still be sending out the signal. It's just it's nowhere is receiving it. And then they would have low T4 and T3 because of that. So those kids we would supplement with thyroid hormone. And for those kids, we wouldn't really measure their TSH because it's not helping us for those particular patients. We would just measure their free T4 levels usually and kind of see if they're in kind of a normal range. And again, looking at their clinical signs and symptoms to make sure they're kind of euthyroid. And then finally, not a me thyroid, but a euthyroid, right? See if you guys are following. And if we're having abnormal hypothalamus, obviously we'd have kind of low levels of everything. TRH would be low because, again, it's not sending any signal. Pituitary would not be affected because, again, it's not being signaled. And then low T4 and T3 as well. Okay. So if like a test question came up and I was like, okay, well, you have a problem where a patient's, pituitary gland was resected, which one of these would you expect to see? And I could put, low T4, high T4, low TRH, high TRH. You can kind of figure that out based on what the negative feedback loops and what all that would look like, right? Again, this is all just kind of following the processes. You can kind of work out the steps in your, kind of going down that logic pathway. Okay. So again, this is where you get a lot of goiter develops, especially if you have iodide deficiency. So again, especially like in developing countries, you can see this more frequently where they don't have as much iodine being fortified in their foods. So because of that, you have the TSH overstimulating that thyroid tissue, so it gets very hyperplasia of that tissue, and you get that goiter that forms there over time. Yeah, you can see later the very pronounced goiter there. Obviously that would be causing some effects, hopefully not to our respiratory tract, but you could obviously see how having all that excess tissue, especially if they're sleeping or something, could cause like an obstructive problem. So we'd like to deal with this and hopefully give them enough iodide to allow that tissue kind of go back down to normal. And again, just looking at the feedback loop of how that would be happening. And again, is there any cases where we're using iodine that could actually get rid of the thyroid altogether? Yeah, I can actually use radioactive iodine to get rid of the thyroid gland. So there's actually some cases where someone has like thyroid cancer. We can actually give them radioactive iodine because your body doesn't really use a ton of iodine except for the thyroid gland. You can actually give radioactive iodine that releases ionizing radiation that can get uptaken into the thyroid gland, and that basically kills off all that tissue, right? So if you had a case where you had really bad hyperthyroidism, you could actually get rid of the or like thyroid cancer, you can get rid of it via that means. And so basically, again, if you had low amounts of iodine in the system, you would have too much TSH stimulation, and again, you just not have enough T4 to actually feed back and stop that process there, right? I had a weird professor in college, and he was always saying that, whenever the nuclear bombs drop, make sure you have enough iodine to take. And we're like, what in the heck are you talking about, dude? And he said, basically, what I didn't know is that one of the major problems, if you survive, so say like a nuclear bomb fell, one of the major problems if you survive the blast would actually be that one of the common byproducts is radioactive iodine. So if you don't have enough kind of excess iodine that you're taking of normal non-radioactive iodine, you can start to incorporate that just by breathing it in through the atmosphere, and so you can end up with hypothyroidism, right? It basically kills off your thyroid gland. So if you ever are preparing your bug out bag, we live in a weird world nowadays, pack some iodine tablets. You may need it. Just saying. Okay. So moving on, we also have calcitonin, which is secreted through these parafollicular cells, or these C cells of the thyroid gland as well. So calcitonin is really important for calcium homeostasis. Basically, this is going to be the flip side. So like insulin is to glucagon, this would be like your SAT question for calcitonin is to parathyroid hormone, right? They're kind of flip side of one another. They are very antagonistic in a lot of ways. And so basically, when you have high levels of calcium in the blood, which would be termed what? Yeah, hypercalcemia, right? So if you had hypercalcemia, you would detect that in those parafollicular cells, the C cells, and you would end up secreting calcitonin. And so basically that's going to do several things, including inhibiting dissolution of calcium from the bone. The osteoclasts are responsible for breaking down bone tissue and releasing calcium into the bloodstream, so you inhibit that process. It also would help to stimulate excretion of calcium within the kidneys, and then you can also have it actually inhibit intestinal absorption of calcium from the GI tract. Okay, so kind of three kind of mechanisms using there to decrease calcium levels within the bloodstream. Okay, and so sometimes we have to actually give exogenous calcitonin. We can give that to some patients who are experiencing hypercalcemia. That can help to drive those levels down and kind of get them back to a normal level. Since that can have some cardiac effects and can have some muscular effects, because we mentioned calcium is really important for muscular contractions. And so if you have too much, you can see like kind of hyperreflexia and kind of some other issues along with that. Okay, so then moving on to the posterior pituitary gland. So two main things that are going to be released from here are going to include antidiuretic hormone and oxytocin. It's actually being produced here in this paraventricular nucleus, and then it travels down to the posterior pituitary where they can be released into the bloodstream. So we've already talked about these two to some degree, so I think this will just to be a little bit of review for what these two are going to be doing. Oxytocin, that's kind of our bonding kind of chemical, and this can mainly be seen during childbirth and also for stimulating milk letdown, as we mentioned earlier. And then antidiuretic hormone. Do you guys remember the other name for that? Vasopressin would be the other good name for that. That is going to be stimulated again by low blood pressure. Usually going to be sensed by looking at the osmolarity within the bloodstream, and it can cause vasoconstriction in some cases. We can actually use vasopressin and give it as for patients who are hypotensive and can actually cause some vasoconstriction, but it also causes that really important salt and water retention, right? So it'll be the other big thing we're going to be looking at. So again, oxytocin stimulates that contractions during childbirth, stimulates that milk letdown, and then going to continue to be used even during that with that suckling stimulus from the the baby. So pretty straightforward there. We also remember that positive feedback loop that occurs. So again, the baby's head during childbirth on the cervix would lead to further oxytocin release. And again, a lot of times we give exogenous oxytocin in order to help kind of send this. Kind of continue this process, speed it up a little bit. What's kind of maddening though is that the brand names for vasopressin and also for oxytocin, they come from the same part of the brain, but they also have very similar brand names, which is odd. Basically for oxytocin, the brand name is pitocin, and then for vasopressin, the brand name is pitressin. So pitocin and pitressin, so you can imagine there's been some mess ups in the hospital world where someone misreads an order, or someone was handwriting it and misread it, and someone could accidentally get the wrong drug, right? So you maybe gave vasopressin to someone who's in labor, and all of a sudden they start to have hypertension and all this water retention. It wouldn't not be any good. And then someone who needs actual vasopressin, if you were to give them oxytocin, they may feel fine, but it's not really going to help them get their blood pressure up and things like that. So again, be careful with drug brand names and look-alike, sound-like products. So not to veer too much into the farm world, but. So again, we mentioned antidiuretic hormone, very useful for helping when it senses things like low blood pressure. This can be determined by things like baroreceptors in the kidney. It can also be used or be stimulated by the osmoreceptors within the hypothalamus. If it senses that the bloodstream is getting too concentrated, the osmolarity is getting too high, it will stimulate that thirst reflex in order to bring more water in, through the GI tract, and also help to retain more of it within the kidneys as well. Just another picture kind of showing the same thing. Again, just increasing water reabsorption, also increasing that thirst response there. Okay, so any questions on the posterior pituitary? We kind of talked about those pretty extensively already. Next, we mentioned parathyroids are going to be located within the thyroid glands, kind of located right on the top there. Usually going to be in the posterior of the thyroid gland. You see kind of 4 of them located right there. So parathyroid gland is going to secrete parathyroid hormones. Pretty easy, right? And this is going to be helpful for increasing levels of calcium within the body. So this is going to be the opposite of calcitonin. When you sense you have low calcium levels in the bloodstream, what do you call that? Yeah, hypocalcemia. Yeah. So you're going to be stimulating both release of calcium from the bones by stimulating osteoclast activity. It's going to help to start to dissolve some of that calcium that's within the bone matrix and release that into the bloodstream. Also going to stimulate reabsorption of calcium from the kidneys, and then also stimulate absorption from the GI tract. Okay, you guys know what else is really important along with PTH to help stimulate absorption of calcium from the GI tract? What other hormone? It's a fat-soluble vitamin. Yeah, vitamin D is really the other important thing here as well. So vitamin D is helpful along, it's one of those permissive hormones, along with parathyroid hormone to help increase absorption of calcium. So, do you guys know what your fat-soluble vitamins are? Yeah, ADEK. So if you ever say the ADEX or something like that, that's usually your 4 fat-soluble vitamins. So vitamin A, D, vitamin E, and vitamin K. So just a little handy tip. So again, there's a very careful balance that's being maintained within the body as far as calcium homeostasis goes. And so again, a lot of this is regulated by PTH, calcitonin, vitamin D, all are really, really important. Because again, if you have too much, say, too much osteoclast activity and starts to break down the bone, what can we run into? Osteoporosis, right? We don't want to do that. We like to keep our bones nice and strong, so we don't want to have too much calcium being released from the bone. But you also want to make sure that you have to be careful with patients who have kidney issues, because they can run into a lot of problems. The kidneys are really important because this is a site where vitamin D is activated. Vitamin D undergoes a few steps of activation, one in the liver, but the final step is within the kidneys. So the problem we run into is you have patients who have poor kidney function. They're not able to produce enough vitamin D. They also end up having problems where they're actually holding on to too much calcium. So calcium phosphate homeostasis in kidney patients gets very, very complicated. We'll talk about a lot of meds we use to help regulate that. But just know this is a careful balance, and kind of screwing up any of these systems, either the parathyroid, the thyroid gland, or the kidneys, can lead to problems. You either have hypercalcemia, you can have calcification of tissues outside of the bone, you can have all kinds of problems associated with this. So. Just another picture kind of showing a similar thing. Again, the feedback loop here for the parathyroid would be that if it senses low calcium levels, it secretes PTH, and then once those downstream effects happen where the kidneys are reabsorbing more, the intestines absorbing more calcium, and the bone is releasing more calcium, those levels rise, and then goes back and feeds back to the parathyroid and says, hey, we have enough calcium, go ahead and stop releasing that. Okay, that's basically the negative feedback loop there. Again, just another picture showing kind of how, again, we can either cause bone to release more calcium, allow the kidneys to absorb more, or stimulate that GI tract. Those are the main things we're going to be doing there. Okay. Yeah, another picture kind of showing the same thing, but again, this shows a better interplay between the calcitonin and the PTH and how these are kind of working opposite to one another, antagonistic. But the whole goal there is to keep your calcium homeostasis pretty straightforward and within kind of narrow range there. Okay, moving on. Next we have the pancreas. You guys already know we're going to talk about the pancreas, right? Insulin, glucagon, absolutely. Right, so just remember that our beta cells are going to be important for releasing insulin. The alpha cells are more important for releasing glucagon. And obviously these are going to be antagonistic hormones to one another. Obviously glucagon raising blood sugar, insulin more responsible for decreasing blood sugar. And again, these are going to be still endocrine glands, but they're still being secreted by the pancreas. Because remember, the pancreas can act as both an endocrine and an exocrine gland. Pancreas is also responsible for sending out a lot of digestive enzymes like your pancreolipase, amylase, protease, things like that into the GI tract. So insulin here, you'll notice that it's being stimulated by high blood sugar levels within those beta cells that will eventually cause calcium to release vesicles containing insulin, but it gets released as this kind of pro-insulin. We mentioned how proteins can be conjugated, sometimes to other proteins, and this is a good example of that, where you have pro-insulin here. This is inactive in its original form. Once you cleave off this C-peptide, eventually you're left with just plain old insulin by itself. And then that is going to be the physiologically active form and can go and cause those changes in expression of glucose transporters in the various tissues there. Again, this is useful if you know that, okay, well, if endogenous insulin has C-peptide, you should have a one-to-one concentration here between C-peptide and insulin. If you were thinking someone had, say, like an insulinoma or some sort of tumor secreting insulin, you can actually measure C-peptide levels. And if that's high, then that would tell you, yeah, the person's releasing way too much insulin. Okay. Versus if it was low, there could be something else going on. Maybe the person's not metabolizing quite as quickly or something like that. So you can have some issues there and try to delineate what the actual disease process is really going on. So again, once insulin binds to the target tissues, whether it be within the brain, whether it be on the skeletal muscle, the liver, wherever it happens to be, it's going to be activating those tyrosine kinase receptors. You guys remember talking about those earlier today? Seems so long ago, but right. But basically, once we have those receptors being activated, we're able to have basically the glucose transporters being expressed out onto through the membrane, and that allows for that transporter to allow glucose into the cell. Because normal glucose should not be able to pass the lipid bilayer. We need those transporters there to allow that to occur. Again, insulin should be increasing glycogen storage, right? Because again, if we have excess glucose within the bloodstream, it can get stored in the liver as glycogen, small amounts in the skeletal muscle, and also in the heart tissue as well. And then all the extra carbohydrates we can store also as fat tissue as well, so I had that lipogenesis that can occur there. Okay. So again, just more pictures kind of showing you very similar processes happening here. Again, insulin should be causing glucose uptake within the tissues, and it can be stored later for energy if we don't need it immediately. Okay. Just another picture here showing the tyrosine kinase receptor. Notice how it has to, once it's activated by 2 molecules of insulin, then that gets phosphorylated. So again, this does require energy for this process to occur, but then that will allow for that downstream signaling process to happen where the glucose transporters get put out onto the cell surface, and then glucose is allowed to come in. Glucagon's going to be antagonistic to that, obviously, and again, this is going to be in response to especially certain stressors or just detecting low blood sugar. It's going to help to increase that, mostly from the liver. I mentioned that liver is the main place where glycogen gets broken down and released into the bloodstream for use in the peripheral tissues. All right. Also, we can see it helps to stimulate lipolysis also in the adipose tissue, especially to get that kind of extra energy source if it's needed, especially when you're kind of running out of glycogen stores. This is a not as fast a way to get glucose into the bloodstream, but it's another way that we can do as well. Again, just more pictures kind of showing you the negative feedback loop that happens here. Again, we can keep our blood sugar in a pretty tight range for the most part by managing our glucagon and insulin levels. Keep in mind that when we start to override this process over a long period of time with, say, poor diet choices and things like that, or we start to deplete our ability to secrete insulin, that's when we run into things like diabetes that start to kind of pop up. And just more pictures kind of showing this process here, and it's kind of a delicate balance. Sometimes we actually run into problems where patients who are, especially who've been hypoglycemic for a long period of time, because again, one of the things we'll do if we have a patient comes in, say that they come to the ER, they're found with like ultramental status, we check, do you guys know what the point of care thing we use to check the blood sugar or the bedside? Glucometer, yeah. Does anyone know the brand name we usually use? Yeah, you always hear AccuCheck. I don't know if it's kind of like Band-Aid. Like Band-Aid doesn't actually apply to every single bandage out there, but that's just kind of the term we use. So if you ever hear AccuCheck, that's what they're talking about. It's a little machine you can just check a fingertip stick and check a blood sugar right there. So if we see that they're low, one of the things we'll do initially is to try to give them glucagon, right? But sometimes you run into problems where patients are hypoglycemic for so long, they've actually already been releasing things like epinephrine, which also stimulates glycogenolysis and gluconeogenesis, but they basically deplete those stores. So after a period of time, you can give them glucagon, but you need to have glycogen around for that to actually work. So some of those patients, they've actually been depleted of that, and they're not actually able to raise their blood sugar that way. In which case, what do we have to do at that point? Yeah, have to give them sugar. So at that point, we would either maybe give them PO glucose, or if they're if they're having problems taking anything by mouth, we give them IV sugar as well. So we can give IV dextrose, and that'll work just as well. But just be aware that glucagon is not always the answer if you have a hypoglycemic patient. It just depends if they have glycogen stores or not. Right. Okay, so the kidney, I never thought of that as an endocrine gland, but certainly is. One of the main things we have excreted here is going to be erythropoietin. And what does erythropoietin do? Stimulates red blood cell production, absolutely. So this helps to, and again, this is another problem you run into with a lot of your kidney patients. So patients who have poor kidney function, they also lack the ability, or start to lose the ability to produce erythropoietin, which would lead to what kind of problem? Anemia, absolutely. So these patients get anemic, and also when you're having to put them on dialysis 3 times a week. Do you guys know what dialysis is? Can anyone describe it? Yeah, it's like an artificial kidney. You basically, hook them up to a machine that will pull their blood out, dialyze it, get it cleaned up, and then stick it back in the patient. But they end up losing a decent amount of blood during that process. So not only do you have kidney patients who are losing blood from that, they also don't have enough erythropoietin, so they end up getting very anemic, which again can lead to all sorts of other problems and not being able to, give enough oxygen to the tissues. They get very lethargic. It's not good. And so in some cases, we actually have to give exogenous erythropoietin to these patients in order to help stimulate that blood cell production. But mainly, you're going to see that this is going to stimulate RBC production within the marrow, primarily within, especially like the the sternum, the hips, the vertebrae. Those are the main places where we're still going to have marrow that is capable of producing those red blood cells. Obviously, more red blood cells, more hemoglobin we have to transport oxygen around, the better we can get that tissue delivery of oxygen. Okay. Next up, we'll have the pineal gland. Does anyone know what comes from the pineal gland? Melatonin, yeah, absolutely. So you guys are probably having like some extra melatonin production in this nice dark room, right? It's after lunchtime and everyone's getting a little tired. Let's see that. Right, so we see the pineal gland is going to be located back here in the roof of the third ventricle of the brain, and melatonin is going to be the primary thing that gets secreted here. Again, it's going to be regulated by the hypothalamus. Also going to help to be regulated by the eyes as well. And it's going to stimulate melatonin production when it gets dark. Basically, things get dark. We're going to have, I'll show you the process where that actually gets stimulated and how that works. This helps to set up the regulation of these circadian rhythms. Can anyone describe a circadian rhythm? Yeah, it's kind of like a natural internal clock. It's kind of like, a lot of things follow circadian rhythms. You see things like, cortisol levels will rise and go up and down according with, sleep and time of day and things like that. We saw that growth hormone is stimulated by sleep. So everything kind of follows the circadian rhythm to some degree. And melatonin is going to be no different than that. You guys know when like the most common time is to have a heart attack? Monday mornings are always like the time where they say when they normally happen, right? Because again, we talk about cortisol levels, how those actually rise in response to melatonin. So you have high cortisol levels when you're during sleep time, and then when you're waking up for Monday morning for work, you're already stressed out about going to work anyway. Heart attack, right? At least that's what they say. I'm not sure if that's still accurate anymore, but that's what I always heard in school. Anywho. Really important here. So basically what you're seeing is that you're going to have these receptors within the retinas of the eye, these ganglial cells in the eyes, and they're going to be able to detect basically how much light is going to be detected within the eye with these photoreceptors. That'll get communicated back to the pineal gland, this pinealocyte. Basically, norepinephrine is going to help regulate this. So when you have a small amount of light affecting those nerves, are going to cause norepinephrine to be released. It's going to activate adenylyl cyclase, right? So our secondary messenger system. And you'll notice that the first step in this process here is going to be tryptophan, right? Tryptophan is always known to cause what? Cause sleepiness, right? So just like we get it from our turkey, you always get really sleepy after Thanksgiving dinner, right? It's probably because you have a high amount of insulin because you consume like 10,000 calories. But also, some of it could be due to tryptophan as well from the turkey. That'll eventually get converted over to serotonin. Tryptophan is a common precursor molecule to a lot of things, a lot of neurotransmitters like epinephrine and things like that. But serotonin is one of the main ones as well, and that can eventually be converted over to melatonin. So that adenylyl cyclase conversion over to cyclic AMP will activate some of these protein kinases, and that will eventually convert the serotonin over to eventually melatonin. Okay, melatonin can then be released, and again, if you look at kind of how that variation can occur throughout the year, obviously, say during the summertime, we have shorter periods of darkness. Obviously, you're going to be releasing less melatonin during that time frame versus the wintertime, longer periods of nighttime. Thus, you're going to have more melatonin. And so that's going to have to regulate the sleep-wake cycle. It's also going to help to regulate things like basically the hormone secretion of things like cortisol, right? So we mentioned cortisol levels can have some effects to rise and decrease during the sleep period. And having things being kind of goofed up here, so if you're in a kind of a high stress, high cortisol state, that can lead to things like sleep disturbances. I mentioned people who have shift work disorder, where like my sister, she's a nurse practitioner. She's been working night times in the ER since, I don't know, it's probably in high school or something. She's been doing it forever. And so her working nighttime really messes up your melatonin, right? Because you're not really getting, when you're asleep, when the sun's out, then you're not really getting into that stimulation there. And so because of that, cortisol levels get off, you can have sleep disturbances, and so oftentimes they're not getting the most restful sleep they could, as if they were sleeping on a normal kind of cycle like the rest of us are, right? So we have things like medications we can have to work with that and other strategies, but again, things get off when you start to kind of mess with your sleep-wake cycle. Or if you have like, an infant, that can also screw it up pretty intensely, as I found out. Apparently they don't like to sleep all the way throughout the night, but whatever. Right, so just note that when you have daytime and you're getting a lot of that specific spectrum of light, especially, so they talk about blue light being one of the things that helps to stimulate this. So you guys know where you get a lot of blue light? Some cell phones, also like from your computer screens right now. So this is actually inhibiting that process. That actually inhibits melatonin. That's why it's, they say to decrease your screen time if you have problems going to sleep, because you're still getting a lot of that kind of daytime effect from those screens. So there's like a nighttime mode like on iPhones now, right? There's the apps and stuff like that. They'll actually cut out that blue light and kind of make it look more yellow. That helps to regulate the amount of blue light you're actually getting shot into your retinas at a constant basis. But anyway, then at nighttime, that's when you stimulate that process, when you get that conversion from tryptophan over to melatonin, and that will help to regulate your sleep-wake cycle. Okay, then we have the thymus. What's made in the thymus? T cells. Yeah, a lot of white blood cells are in the thymus. And this is going to be regulated by thymopoietin. This is basically going to be increasing our white blood cell production within the lymph nodes. We'll talk a lot more about this when we get to the inflammatory system, I think, in section 2. I'm actually working on those slides right now. Okay, so any questions on any rest of the endocrine glands? All right, you guys are all endocrined out? You guys like, I'm autocrine? Okay. You guys really don't have to laugh at any of those. This does not affect your grade. Okay, so we'll continue on. We'll look at looking at the sensory apparatus within the body. We're going to look at the physiology of both how we can experience touch. We'll also see sight, smell, taste, all the kind of good stuff in the upcoming slides. So we're going to start with talking about the skin, then we'll work our ways to the eyes, and then talk about ear, nose, and mouth. So there's several different types of receptors that are going to be involved with our senses. So chemoreceptors, what do you think affects chemoreceptors? Yes, chemicals. That seems like the pretty obvious one. What are some different kinds of stimulus, do you think? Smell could be a big one. So like different chemicals you smell can activate those chemoreceptors. Anything else? Think about things like pH as well can affect that. Like, lots of different things can affect these chemoreceptors. You also will have some chemoreceptors within the blood, and that can actually determine things like osmolarity, or it can determine things like the pH of the blood or CO2 levels, things like that. So any kind of chemicals that are affecting these receptors would be considered chemoreceptors. Obviously, photoreceptors. Light, yeah, absolutely. Thermoreceptors are going to be responding to either heat or cold. And then we'll talk a lot about mechanoreceptors, and these are going to be stimulated by either deformation or some kind of conformational change of the receptor. This will be more important, especially for touch, but then also for hearing as well. And we'll talk about like our vestibular apparatus and see how that can be affected by those mechanoreceptors. We'll also talk about some pain receptors. This is called, do you guys know what the term for sensing pain is? And nociceptions. We'll talk about the nociceptors as well as far as pain receptors, because again, that's a huge deal because we're in the middle of an opioid epidemic, and pain is a big problem with that, right? So we'll talk more about those in detail in just a few minutes. So again, stimuli from pain can include things both heat and cold. I'm sure you guys have both felt extremes of temperature that have led you to ow, that hurts. Especially something especially cold. Pressure can lead to this. Certain chemicals can. So if you imagine things like capsaicin, right? Where do you find capsaicin? Peppers, right? It actually activates substance P, which is a powerful nociceptive chemical, right? That helps stimulate your pain receptors. That's why you get that intense heat kind of feeling. A lot of it comes from these nociceptor receptors there. Again, pain perception of pain can be influenced by lots of things. So if you imagine, emotions, if you have expectations for pain, a lot of times, especially things like taking a Band-Aid off. Oftentimes, actually, just taking it off is a lot less painful than what you would expect it to be, right? Or getting a shot or things like that. So oftentimes you're going to find, especially with pain, there's a high degree of anxiety that comes along with this, which is why frequently, especially for like small children, when we're trying to say like, one of the worst things we can do to a small kid, according to them, is put an IV in, right? They are freaked out by IVs. They don't like to be stuck by a needle. It's bad news. And so a lot of times it's not necessarily the pain that's the biggest issue. It's just that anxiety, that feeling of fear from about to be stuck by a needle. So a lot of times we have to give them anxiolytics, which are drugs that help to alleviate anxiety, to help kind of calm them down enough so they can stop squirming when we actually put the IV in, right? So a lot of things that can be affecting pain sensation. A lot of it can be, again, very subjective kind of experience for a lot of patients as well. We'll talk more about that detail a little bit later on in this presentation. We also have proprioceptors, so those are going to be receptors found in both in the muscles, tendons, and joints. These allow for us to kind of know our sense of position, allows for kind of fine muscle control. Right. We also have cutaneous receptors that are responsible for things like touch, pressure, heat, cold, and pain, mainly found within the skin, obviously. And then we'll talk about our special senses and kind of how those differentiate one another a little bit later. You can notice that in a lot of cases you're kind of incorporating multiple types of feedback or input in order to actually have a strong sense of anything. So for instance, if you're running and you have to make a corner, it's not just that you're getting proprioception from your joints to know how to run or where your body's at in certain motion. It's also feeling in the vestibular apparatus, trying to figure out which way is your body turning, right? Your body can make a lot of sense from a lot of those inputs. Also vision as well. So again, you can make kind of predictions on, I know I'm going to be turning this way, here's how my body needs to respond to that. Most of it you're not really conscious of at the time. It's just incorporating lots of that feedback into one signal saying, okay, now I need to do this in order to make sure I don't fall on my face, right? So we'll talk about how we can incorporate a lot of that through these various senses a little bit later. Okay, so basically what we're seeing is when we have activation of these senses, it's mainly going to be being transmitted via action potentials, right? So we've already talked a lot about action potentials. Essentially what you're seeing here, especially with like, and for instance, like say this is a, this is like a Pacinian corpuscle, if I remember the book right. But imagine this is one of your touch receptors within the skin, right? Basically what you're having here is that in order to experience touch, there has to be some kind of mechanical deformation of the actual receptor itself. So imagine if I'm kind of putting pressure from this side here, it's basically going to push all this fluid in this way, and you can eventually open up these receptors here, right? So these are kind of stretch receptors, and once they open up, these ion channels open up. And again, we said that on the inside of a cell, it's normally more negative or more positive? Usually more negative on the inside, right? So we said that have that resting potential like negative 70 millivolts on average. When you have that mechanical deformation, and you're allowing for these new ions to flow through, that's going to cause an action potential once you hit that threshold, right? That receptor potential can then be transmitted down the nerve, and then once you get here to these coats of myelin, this node of Ranvier, right? So you have these bits of myelin. This allows for more quick conduction of these action potentials down the nerve, and as you travel up to the brain, you get that sensation of, yes, there's pressure here, or there's some sort of sensation going on at this particular receptor, right? Very similar process here. We're going to see the action potentials being propagated. Sometimes we'll be dealing with myelinated neurons, sometimes they'll be unmyelinated. Transmission is faster in which one? Yeah, myelinated, always going to be faster in those, and so that'll make sense when we talk about the different means of reception there. So again, once those ion channels open, that's when we can trigger the action potential. Usually sodium is going to be one of the big players here to allow sodium into the cell. That reaches that threshold to trigger the action potential, and then it gets transmitted to the brain. Also, remember what helps to reset that action potential at the end of the discharge? Yeah, remember that sodium potassium ATPase pump? Right, that's also really important here to make sure we're getting back to our normal resting membrane potential. If you don't have that, you would never be able to get back to kind of your baseline unless you wouldn't have any more action potentials. You wouldn't feel anything. Okay, and then looking at the frequency of how often this process occurs, you're going to have repetitive action potentials, and so you can have very slow action potentials that come up to very fast, and your constant signals being sent there. And we'll talk about how adaptation occurs and how you can have some tissues that will adapt very quickly to where, if you imagine, like, can you feel your shirt on you right now? If you think about it, you probably can, but normally you don't really feel that you have a shirt on or you have shoes on or something like that, because you have very fast adaptation to a lot of those kind of pressure receptors and those proprioreceptors. That's not proprioreceptors, but the kind of telling you, like, okay, yeah, that pressure's there, but your brain kind of shuts that down over a period of time. As opposed to other things like pain, you don't want to have adaptation to, because if you're in pain, you need to know about it, because that usually means your body's in trouble, right? In a lot of cases. We'll see that it's not always going to be productive, especially with chronic pain issues, but that's how it typically goes. So you can have phasic responses, and so this is going to be responding with a burst activity when a stimulus is applied very quickly, but then we adapt to that stimulus, and it's going to start to slow down those action potentials over time. That allows for having not necessarily as constant of an input, right? So this would be the case of like those pressure receptors, like on your skin, especially for like not very sensitive skins, like think about your back or your shoulders or something. You don't need a lot of very fine sensation there, because it's not like your fingers or something. So you'll notice that will start to slow down, and then once the stimulus is withdrawn and you apply another stimulus, it'll start up this action potential process all over again. Okay, and so this is important because once you this is going to be good for sensing changes in input rather than sensing a constant input. Okay, so for instance, if you're running your finger over, say, Braille, right? So if you had vision impairment, you want to be able to feel all the different indentations, and so by feeling those rapid changes, as opposed to just putting it on your finger and then you don't feel anything else after that, gives you that kind of fine ability to sense the changes in texture and whatnot. So you can also experience this with like smells, with temperature. Again, do you guys like feel what temperature it is right now? I do, because it's like really hot up here, but I'm sure you guys are probably sitting in a nice like 72 or something. You're probably not noticing the temperature quite so much. Smells another big one. So for instance, like, you guys ever like change deodorant scents? Like you notice it like for the first couple of days, and after a while your brain kind of shuts down that input because it's not really useful anymore, right? Same thing's kind of happening. You get that adaptation to it over a period of time. Also stinky smells as well, but I like to focus on the good smells. We can also have tonic receptors. These are going to be things that retain high firing rates as long as the stimulus is going to be applied. So this is good for signals that we want to have constant awareness of over a period of time. And so, for instance, you know, think about things like the vestibular apparatus. We want to know what position our head's in at all times. If we started to shut down that feedback, I'd probably just fall on the floor, right? No good. Pain's another good one. Think about baroreceptors, which what do baroreceptors detect? Usually like pressure, especially within like the veins in the venous system. Chemoreceptors, we mentioned, can be looking at things like osmolarity, the cardiovascular system. Like that's going to be really important. We always kind of have a good sense of where we're at so that we can respond to it immediately. As soon as the stimulus is withdrawn, it goes back to kind of baseline. But as long as that stimulus is there, it's going to be firing the same action potentials as it was at the very start. Okay, so a very low amount of adaptation that occurs over time. Again, looking at things like, we mentioned spinal corpuscles, like those adapt very, very quickly. So that way when you have small changes in either vibration or in indentation or anything like that, like you sense those changes very quickly, and then you adapt to them very quickly as well. So that's going to be good for kind of detecting fine changes there. Hair receptors also adapt very quickly, but things like muscle spindles, joint capsule, like we want to know like what position our joints are in at all times. So that way we can respond effectively if we have a sudden change, right? So if the floor dropped out from under, you could know something's changed there. Okay, so specifically moving into talking about the skin. So we have a lot of different types of cutaneous receptors available for sensation. We have free nerve endings. These are going to be probably the most kind of ranging widely in as far as what they respond to. Some of them are going to be good for detecting things like light touch or pressure, but also these are the free nerve endings that respond to pain, and also we'll talk about cold and heat and how they kind of respond to different temperatures as well. So those are the main things that respond to that. You have these Merkel's discs, which respond to touch, mainly like indentation. You have Meissner's corpuscles, which are good for detecting vibration and touch. Spacinian corpuscles, these are again very good for rapid changes in mechanical state of tissues or like vibration, so you can detect if things are changing the rate at which it's vibrating. And you also have these Ruffini endings that are a little bit deeper, and they're responding more to skin stretch as well, right? So they're kind of all being incorporated into these similar signals, so that way you have a good sense of like, okay, what exactly am I feeling right this second? You guys ever done that thing like in elementary school, like they turn the lights off and it's like Halloween time, and it's like, oh, here's witch's hair, and you put your hand in a bunch of spaghetti. Here's your eyeballs, and I touch some grapes or something, right? So all the sensations. Mind paints a picture. Okay, so again, just another picture showing with these different receptors are going to be detecting specifically. So how do these sensory pathways get the signal from your skin up to your brain? There's going to be two main ones that we'll talk about. The first one is going to be this dorsal column medial lemniscal system. And then we're going to have the anterolateral system. These are very catchy names, I'll have you know. But basically, with the dorsal column system, you're going to have signals traveling through the dorsal columns, as the name would indicate. I'll show you pictures in a second, this will make more sense. But basically, the signals are going to be synapsing and crossing over to the opposite side in the medulla. Have you guys covered this yet in anatomy? Okay, you may cover this. I'm not sure. I haven't actually taken that class because I'm not a student. But basically what you're going to see is going to cross to the opposite side, right? And you'll see that a lot with a lot of these sensations, that your left side of the brain detects stuff on the right side detects stuff on the left side, right? So it's probably not a foreign concept to you guys. But they're going to synapse and cross over in the medulla, and then you're going to be traveling through the to the thalamus, through this medial lemniscus system. So that's going to be kind of the second part of the name there. And then the thing that this is good for is very high spatial orientation of the nerve fibers in respect to where they're coming from. So this gives you a sense for if I'm feeling something at the tip of my finger versus say further more proximal to the hand or something, right? So this is going to be giving you a high degree of spatial awareness. These are going to be large myelinated fibers. So the bigger the fiber, the more myelinated it is, the faster the transmission time, right? So 30 to 110 meters per second. Like, and how tall are most of you guys? Like 1.5 meters, 2 meters at the most, like so it's a very, very fast system. Transmit these signals near instantaneously. On the other hand, you have the anterolateral system, and this is you're going to see will synapse within the dorsal horns. So this will be synapsing further down in the spinal cord and the spinal gray matter. It'll cross to the opposite side of the cord, and it's going to ascend through this anterior and lateral white columns of the cord. So that's where they get that name from that standpoint. This will be terminating in the brainstem and the thalamus. And even though it's a little bit slower transmission, only about 40 meters a second is where it kind of caps out at, this will give us a wider range of inputs, right? A wider range of sensations. So things like pain, warmth, cold, crude tactile stimulations. Not as much as the spatial awareness, but in a lot of cases we may not need a lot of spatial awareness for what we're sensing there. So what that means is that with the dorsal column medial lemniscal system, we're getting things where like a high degree, touch with a high degree of localization. So we want to know exactly where this touch is coming from. If we need to know fine gradations in intensity, right? So if you're feeling, slow vibrations or very fast vibrations, something like that. If you need to know about movement against the skin. So again, like you may not feel your shirt right now, but if I were to move your shirt on you, you would end up feeling that sensation, right? As it kind of moves against the skin. Positions from the joints and also pressure sensations, right? So it's a very high degree of sensitivity, high degree of localization, very fast transmission there, okay? On the other hand, you have the slower anterolateral system. This is good for things like pain, thermal sensations, crude touch and pressure, like the itch reflexes and tickle reflexes come from here. And then also like sexual stimulation will also come through this anterolateral pathway. So some pictures here will make more sense. So here's the dorsal column medial lemniscal pathway. Notice here like kind of what the input stimulation the book is kind of giving you here. So here we see like feathers, right? So kind of if you need to know kind of fine sensation exactly where this feather is tickling the person at, although I said the tickles come from the anterolateral, but this is just kind of showing you like if you have a fine sensation going to the fingers or the toes or something like that, here's how it's going to transmit. The base is going to go through the dorsal horns. It's going to synapse here in the lower medulla, right? So it's going to cross over to the contralateral side. Right, so if you got a stimulation from the right side of the body, it's going to go over to the left side of the brain. It's going to synapse here up in the thalamus. Once we're here, it's going to go over to the somatosensory cortex. We'll show you a picture of what that looks like in a second, how those sensations kind of go there. Again, you'll notice how the nerves is going to give us a fine sense of kind of where the sensation is actually coming from based on where it's going to be finally, kind of the terminal kind of terminal location of the action potential. You'll find, especially kind of top of the head, you're going to have more sensation from like the lower extremity to the trunk, upper extremity, and then finally the face gets a decent amount of stimulation here as well. And it'll kind of show you that really creepy picture that kind of shows you where you get most of the stimulation from in just a minute. Again, just know that, again, we're having this contralateral changeover within the medulla. And it's going to be synapsing here in the thalamus, and it's going to go up to the somatosensory cortex. It's a basic pathway we see there. Again, like I mentioned, I feel this is a very creepy picture, but kind of gives you an idea of the localization, how we can tell where stimulation is specifically coming from. And you notice that the areas with larger areas of the somatic cortex are going to have a larger number of sensory receptors. So more receptors or more neurons are synapsing up here and giving us a sensation. So you notice like you have pretty fine sensation in like the lips, right? Versus somewhere like your leg. Like you don't need a lot of fine sensation necessarily in the leg, but things like the fingers get a lot more kind of real estate up here in the brain than somewhere like your shoulder. Okay, so again, you don't have to memorize it specifically, at least for my purposes, where all these sensors are going into, but just know the things that require or things that have a high degree of sensitivity are getting a lot more brain power kind of associated with it, right? Or at least more brain real estate. All right, so looking at things, so again, still in the dorsal column, medial lemniscal pathway. Again, this is going to be good for fine touch receptors. So again, if you ever played with one of these like 2-point touch receptors, or if you're doing that thing like in school where like you put like 2 pencils on and you see how far away they have to get before they can actually detect 2 different points, right? So where do you get like the finest sensation there, the finest, the closest? You can feel 2 different points. Yeah, like the index finger. You also get a lot of good. It's probably the best, right? But like the hands are a pretty good point where you can find, a fine gradation between 2 points of contact. But somewhere like the middle of your back, probably not. They need to be pretty far apart, right? And it has to go with how many nerve endings you have available and how many receptors are being activated within those specific tissues. So, for instance, you can detect different stimuluses based on how many receptors get activated at the same time. So for instance, if I have a very weak stimulus, I just had like a little tiny pinprick on the end of my finger, I may only have a few of these receptors that end up getting stimulated by that weak stimulus, right? Only a few of these get activated and then travel up through and into the brain. So I notice, okay, it's a weak stimulus. As I get a bigger stimulus, I had like something like a hammer hit my finger, right? That's going to be a lot bigger stimulus. It's going to be recruiting a lot more of these cells in here, a lot more of these neurons, and that's going to summate all those signals together to say, okay, to the brain, this is a lot of pressures coming here, a lot of stimulus is happening all at one time. Okay, so that's how we can kind of tell the difference in gradation between kind of fine differences in either pressure or things like that. On the other hand, when you're trying to tell the difference between two different points, a lot of it has to do with this kind of lateral inhibition that occurs within the neurons. Because you notice, like, if I were to have two different points here on, say, very close to the fingers, like, you're activating a lot of the same receptors here. You're noticing how these nerves have several different points of contact, and you notice there's a lot of overlap here between these two nerves, right? What you end up finding is that the actual points here, there's going to be some lateral inhibition, and that helps your brain kind of determine, like, okay, I'm hearing all this activation here, and it's going to start to cause some lateral inhibition to the sides where I can actually shut down some of that input. So I can say in the fingers, when I have a lot more nerve endings and whatnot, I'm able to differentiate 2 points that are very close together versus somewhere they have a lot less nerve endings. Okay, if you get too close together, you see they kind of just blend together, and you're not really able to tell the difference. And this is important because if you have someone who has like altered perception, and like say you apply something to apply 2 points very close together to the finger, and they don't really sense that, that could show you there may be some nerve damage going on or something else happening. They're not really conducting that signal appropriately. Okay, so you can see that with trauma and different things like that. That making sense so far? Hopefully, maybe old news to you guys still. Okay. Okay, on the flip side, we have our anterolateral pathway, and so again, we said this is better for things that don't need a whole lot of like localization necessarily, but are better for things like pain reception. This is going to be good for crude tactile sensations. Heat and cold are another big one that travels through this pathway as well. Not quite as quick as the dorsal column pathway, but still pretty good for the most part. So for instance here, if I were to apply a pain signal, say to the hand or the foot, notice here that the synapse, the first synapse here happens within the dorsal root, right? So we're having a synapse here, it's crossing over to the contralateral side and then traveling up this anterolateral pathway. So notice here it's kind of anterior and lateral, part of the white column here. It's going to travel up, and they're also going to notice that it will synapse here in the thalamus as well, and it still is going to terminate within this somatosensory cortex. In this way, we can kind of combine these signals together to know, okay, if something is applying pressure, but it's also hot, or it's also cold, or whatever it happens to be. So again, all the signals are kind of going in the same place for the most part. It's just a matter of what their pathway is and how it eventually gets up into that somatosensory cortex. As far as pain sensation goes, there are kind of two major types of pain that are felt. There's fast pain, and there's going to be slow pain, right? Fast pain is usually felt within a very short period of time, say within like 0.1 seconds after a stimulus is applied. This is where you get a lot of like kind of sharp, pricking, acute pain. You normally don't feel this in the deep tissues, right? So if you guys, if everyone's ever had like appendicitis or something like that, but when you have that kind of deep organ pain, like it's a lot different than something like, I just cut my finger, right? So like cutting your finger is like that kind of fast pain versus that slow pain. It's something that takes a little bit longer for you to feel, and it can slowly increase over time, say minutes, seconds to minutes. So you get that kind of aching, throbbing, kind of chronic pain. It can be both felt on the skin, certainly feel it there, but also in a lot of deep tissues as well. Sorry, I just realized I'm running over. I'll give you guys a break in just a second. Again, the pain receptors are going to be located within those free nerve endings primarily, and then we're going to see that it can respond to both mechanical, thermal, and then also chemical pain receptors. The chemical usually is going to be responding to, or usually going to be slow pain in general, right? Slow pain is going to be related to things like bradykinin, histamine, serotonin. So you think about things like say you cut your finger, it hurts immediately, right? But say you put a Band-Aid on, the next day though, it's just kind of throbbing, it's kind of achy. Like a lot of it has to do with that slow pain. Those chemoreceptors are detecting things like that serotonin and that inflammation that's happening there. So the pain receptors typically adapt very slowly, if at all, because again, if you're having pain, your body typically needs to know about it so it can maybe do something. Like my hand's in a fire, I probably don't want to adapt to that. I probably want to remove my hand as quickly as possible. Okay, so. And actually, it can actually become more sensitive over time. This is a big problem with chronic pain patients. We have this term called hyperalgesia, where especially if they don't have their pain well controlled, they can end up just getting more and more painful over a period of time. So that can lead to worsened reliance on opioid medications, worsened addiction, and all kinds of bad problems. So anyway, all right, I'll give you guys a 10-minute break now. We'll come back and then finish up. So we're continuing to talk about pain, something you guys are very familiar with today. I'm sure as the rocking migraine you probably have from all these physio lectures are probably doing to you. Anywho, we mentioned the two main type of pathways here. So there's going to be fast pain and slow pain. You'll notice that, again, these are coming from that anterolateral pathway where, again, there's synapsing here in the dorsal horn. They're going to cross over to the other side and go through the anterolateral pathway here. The thing to note is that the fast pain, again, fast pain usually is going to be linked up with you wanting to know specifically where that pain is coming from. So you want to have a good degree of localization for it. So we talk about with fast pain going through this neospinal thalamic tract. And you kind of notice that here we have these pain tracts coming up through the spinal cord. You notice the fast pain fibers are going to be going to those somatosensory areas, right? So the pain will be synapsing in the same place where you're feeling the pressure, where you're feeling the heat, whatever happens to be at the same time. And that's good because we can coordinate with our tactile inputs to see where that pain is coming from, which is a good thing. And the main neurotransmitter here we'll see is going to be glutamate, which is an excitatory neurotransmitter. Okay, we mentioned glutamate is kind of the opposite of GABA, which GABA being like the kind of main brakes on the system. And then for the slow pain, we have this paleospinal thalamic tract, which is going to be have pretty low ability to localize the pain. This will be really important when we talk about reference pain in just a minute. But you'll find that these are going to be nerves that release glutamate and also substance P, which I mentioned with being like capsaicin or like in spicy peppers and things like that. So you notice here that the fast pain fibers are going to be these kind of small fibers. I'm sorry, the slow pain fibers are the ones kind of radiating off of here, kind of in the brainstem. Okay. So that's the reason why we can actually use capsaicin as a way to relieve pain. We can actually use that. So for instance, we use like for things like arthritis, where you can actually rub capsaicin in and around like a joint, like say like an achy knee from arthritis. You can actually rub that in, and by depleting those substance P, by using capsaicin, you can basically deplete substance P in those nerves, and it will actually lead to having less pain sensation actually traveling up this pathway. So that's one way you can actually deal with pain without actually using things like opioids or using like NSAIDs and things like that. So you can use that more locally. On the flip side, this is actually kind of an interesting thing. When we have to reduce fractures, so say you have a displaced fracture and you come into the ER, we use a drug called ketamine. You guys ever heard of ketamine? You know like the street name for ketamine? Special K. Yeah. It's one of my favorite drugs to give to people. It's an amazing drug. But one of the cool things is it's actually, I give it to people therapeutically, not recreationally. I swear. So anywho, so ketamine is really cool because it's an NMDA receptor antagonist, which is actually a glutamate receptor. And so it makes sense because, if you have to like reduce a fracture, like, it's going to be a pretty painful procedure, right? Because you got to get that broken bone into place. And so what we actually do is we'll give, and the kids respond super well to ketamine, we'll give them ketamine, and it actually will start to block those glutamate receptors, especially with this fast pain pathway. So by blocking those receptors, basically, even these pain signals are still traveling up into through the spinal column, you're basically blocking it from getting really any of that signal being transmitted to the brain. So we call it a dissociative anesthetic, where basically the patient almost feels like they're having an out-of-body experience, where they don't really, they're still conscious, like they can still breathe and they can still like move their eyes and things like that, but they're not really there. They're off in Disneyland or wherever they happen to be. So it's a really good drug because it helps to block those pain receptions. So that way the patient, you can get your procedure done, whatever you need to do, and the patient doesn't really remember anything. They don't really ever experience any of that pain. So it's a really good way to deal with pain for those kind of short-time procedures there. So I'll talk a lot more about that when we get to like procedural sedation and things in pharmacology. But Special K is a very, very cool drug from that standpoint. Not good for dates. Never for dates. Okay, so again, we have an analgesia system built into our spinal cord, right? Because I mentioned, like, we have these pain fibers. They're not really good at adapting. We want the kind of have that constant signal to know, yes, we're still having pain. But that's not always super useful for the CNS to be aware of, especially like chronic pain issues. And so we have a way to blunt that pain response to some degree. And so we can use that with certain neurotransmitters. Some of the major ones include things like serotonin. Can be really useful with this because this actually helps to stimulate release of enkephalins. And enkephalins are going to be basically our body's own opioids. Right, very similar to things like morphine and heroin. Basically, some of the major ones you'll see being released include things like beta endorphin, which comes from the hypothalamus. You'll have this metenkephalin and leuenkephalin, and then dynorphin. All those are being released within the brainstem and also the spinal cord. So essentially what you can see here, basically, what you see from these paraventricular nuclei, you're going to have these signals that are transmitting down here. You can have this mesencephalin, Basically, it's going to be synapsing within the spinal cord, and that can actually send down some of these enkephalin signals down into the spinal cord. So you can actually end up having a blunting of those pain responses that are coming in by basically inhibiting the synapse right here in the spinal cord. So if you inhibit that signal, even though the pain may still be there, the signal is never reaching up into the brain, right? And so it's one of those things where, like, I've never taken opioids therapeutically or recreationally. I think I had my wisdom teeth out when I was like a kid, and they probably gave me like Darvocet, which is kind of a wimpy opioid anyway. But the way it's described sometimes is that, like, yeah, you know that the pain's there, but you don't really care about it, right? Because it's able to blunt that signal, you're still able to feel some of that pain, but it's basically able to not really respond to it as fully as you would if you didn't have that signal there. So exogenous drugs can do this, right? When we have patients who are going into labor, we can put a epidural in that actually gives opioids directly to the spinal cord to inhibit those kind of nerves. We can also do it with our own body, releasing things like the endorphin. So it's kind of a nice built-in kind of opioid system to blunt some of those pain responses. Okay. So we also had this referred pain. So have you guys heard of referred pain? What is referred pain?
Visceral pain.
Visceral pain? Okay, that's a good description.
Pain that you may feel in a different area, but it's not actually the problem. You know, it might be coming from a different organ.
Absolutely, yeah. So it's basically like you're getting pain signals from kind of deep visceral organs, but you're feeling it at kind of distal sites to that, right? So what's kind of a classic one?
Gallstones in your right shoulder.
Okay, gallstones in the right shoulder. That's a good one. What's the kind of the other one I heard some people mention? Yeah, heart attacks are a big one, right? So when you have a heart attack, right, your heart is obviously experiencing pain. Where are you feeling that at? In the jaw, left arm, right? So you're having those signals down. And so the reason why we have that is because of the fact that we don't really have a good way to transmit kind of pain signals from those organs, and at least a really good way to localize it, right? Because we mentioned they're going through those slow pain pathways. So we know that there's pain there. We just don't know really what it's coming from specifically. And so the way that we see this kind of referred pain occurring is because you're noticing a lot of these synapses are kind of sharing the same neurons. So you can have these visceral nerve fibers that are coming in signaling pain, like if you have something like a heart attack that's occurring. And then also these skin nerve fibers are kind of synapsing at the same neurons. So for instance, like, heart pain, you can see coming through to the shoulder and the arm. It can also radiate up the neck and into the jaw. And this happens for lots of different areas as well. So for instance, liver and gallbladder can be referred out here to this part of the abdomen. And it happens for lots of different places. So just know that that's why we're having those sensations, is because of the fact that those visceral nerve fibers are being innervated by the same kind of skin fibers, and so when you have one being signaled, it's kind of giving you a signal that, hey, there's pain happening here, but it's even though you're not sensing it at the actual organ itself, right? So no one says, "Ow, my gallbladder hurts." Like people say, "Oh, my stomach hurts," right? That kind of thing. Okay, next up is thermal sensation, and so again, this is going to be regulated not only by pain fibers, but also cold and specific cold and warm fibers. And so you can find that pain receptors can be triggered by both extremes of temperature, right? So I'm sure you guys have felt something so cold that it hurts, or something so hot that it hurts, right? So those can all be regulated through the pain receptors as well. And so basically, the receptor density can vary based on the type of tissue, but in general, you're going to have 3 to 10 times more cold receptors than you actually have warm receptors that you can experience there. So for instance, on the lips, you have a ton of 15 to 25 cold spots per centimeter cubed of the lip, so you can detect heat and cold very well there, versus something like on the finger, maybe only 3 to 5 cold spots per centimeter squared, and for something like on the trunk, very few cold fibers there. Okay, so the hands are going to be a little bit more sensitive, the lips even more sensitive to that. And we'll see that the receptors can adapt slowly, but they'll never be completely, right? So the best thing you can notice is going to be changes in temperature rather than the actual temperature itself, right? So you ever heard of, like, if you wanted to like boil a frog, like how you would do it? You start with the water like room temperature, and then you gently increase it up. So if you do slow changes, more difficult to detect than if you were to like throw a frog into a boiling pot of water. I don't actually advocate for doing that, but it's an example from Dante's Inferno. If you guys ever seen that movie, probably well beyond your guys' time. Anywho. Point being, though, is that you can detect changes in temperature very easily, right? So have you guys ever like gone from like a jacuzzi and hopped into a pool, or gone from the pool and hopped into the jacuzzi? How did that feel? Invigorating, right? Because you can sense that big change in temperature very, very well, right? So especially if you go from hot to cold, like you're gonna know that's freezing cold, right? Because you had some adaptation to that heat input, but now that you're having a major change over to something a lot more cold, you're gonna sense that pretty well, right? And so you can notice, like, you're gonna have kind of various receptions to this, and based on how the cold and the warm fibers are kind of interacting with one another, that kind of gives you a sense for what the temperature is. Obviously, if we're in extreme cold pain, you're going to be experiencing more pain signals being sent there. Heat, the same thing as well. But typically, you have a lot better ability to differentiate cold temperatures than you do necessarily warm temperatures. Okay, so that's pretty much touch. Any questions on that? All right, moving on, we're going to start talking about some of our cranial nerves and also some of our other senses of detection. We'll go over these different nerves and kind of where they fall into place as we go along, but just know you can refer back to this table to know which cranial nerves are responsible for which either muscle movements or for which specific transmission of certain senses. So for instance, like, if you know that cranial nerve 1 is going to be really responsible for olfaction, which is another term for what? Smell, right? So it's important to know that cranial nerve 1 is good for smell, right? We'll talk about, the optic nerve being responsible for, obviously, vision, things like that. So it's important to know which cranial nerves go to what, and we'll talk about those as we kind of get them into more detail. Again, we have several. We're not actually going to probably cover all of these necessarily, but the ones we cover will be certainly testable, okay? So if I don't really talk about them in the slides, if they're on this table, they're probably not going to be testable. But if I do talk about them in the slides, fair game, right? Okay. Anyway, we have quite a few of these cranial nerves that we will go over. Okay, so let's talk about the eye. So here's an eye, right? Different parts we're going to be talking about here, but again, here's a nice table you can go back to and kind of reference and see like what the different parts of the eye are actually going to be doing. We're going to go over these in detail as these slides come up. So anywho, we're going to talk about primarily the sense of vision here. We'll also talk about kind of how we control eye movement, especially with some of these nerves here, and how the signal is being transmitted of vision when light passes through the eye and gets transmitted back to the brain. So what is the pathway for light to actually be transmitted to the brain? Essentially, we're going to be going through the anterior cavity initially, right? Basically, we have the anterior chamber here, which is going to be everything basically in front of the iris, and you're going to have this posterior chamber, which will be basically everything behind it, right? So essentially, light's going to be traveling through the cornea here. It's going to be traveling through the pupil, right, which is being surrounded by the iris. It's going to then hit the lens. That light will then be refracted, and it's going to be transmitted back here to the retina. Okay. Notice here that here's the retinal nerve, the optic nerve. The fovea right here is going to be the primary focal point for where light's going to be. This is basically where you get the clearest image. It's also where you have the most kind of sensory inputs for light that happen there, right? So this is kind of the center of vision. Everything else is going to be kind of also be picked up by that retina, but that's where the kind of the highest sensory input is going to be at right there. Okay. Obviously, the sclera is going to be this kind of white portion of the eye surrounding that. Conjunctiva being kind of the tissue outside of that. And we're going to talk about how how we can control refraction of light with the lens. I'll talk about pupillary constriction, how we can affect light that way, and I'll also talk about how we keep everything kind of nicely lubricated and cleaned and all of that, with especially with aqueous humor formation. So look at the internal anatomy. Again, cornea is going to be the first place where the light is going to be hitting the eye. The pupil is going to be able to, what does the pupil do? Anything? Yeah, it's basically kind of like our ability to dictate how much light is actually going to be coming in. If any of you guys are like, photography nerds or anything like that, you guys will be very familiar with a lot of the apparatus that you see here. Basically, the pupil is going to be dictating how much light is going to be coming in. So I'm going through the lens. The lens allows us to both tighten and loosen that to allow for better kind of better correction of the light and how much we're going to be refracting that, right? So everything should be hitting our focal point back here in the retina, and again, this is going to be the fovea where that's mainly going to be hitting. These nerves will be triggered and then be transmitted down to the optic nerve. Main places we're going to be detecting light would be the rods and cones. I'm sure you guys have heard of those before. That'll be traveled to the optic nerve, and then we'll talk about that pathway a little bit later, how that gets transferred through. So I mentioned the optic nerve here is cranial nerve number 2. We'll have the fovea here, which again is going to be the highest number of nerves are going to be there. This optic cup is where basically the arteries, veins, and also the optic nerve are going to be coming through. You can notice the arteries and veins that are going to be located within the eye as well. The macula is basically just going to be this kind of area surrounding the fovea. Again, there's still going to be a large number of rods and cones there. They're going to be able to detect a large number of light. This is, again, where most of the picture is going to be kind of focused for the most part in the eye. Okay, so looking at the visual pathway, again, vision, we cannot see all ranges of light. That would be pretty cool if we could, but unfortunately we cannot. We can only see a very narrow spectrum here of this visible light, basically from around 400 to 700 nanometers of wavelength. Okay, anything above that's going to be considered like infrared, then you get like microwaves and whatnot, and then anything below that would be ultraviolet, and then X-rays and gamma rays. So we can only see a very small portion of that. At least that's what our photoreceptors can be at least excited by from that wavelength of light. So what happens here, as I mentioned, is the light is going to pass through the cornea. The cornea is going to, now the cornea itself is going to have some effect on the light, but it's not going to have a ton of effect. But certainly, if you were to have things like, an abrasion on the cornea, if you had any kind of abnormality there, that can certainly be affecting the way the light can be transferred through here. But typically, you're not going to see a lot of effect. Basically, we're going to be traveling through the anterior chamber of the eye, through the cavity, and then it will pass through the pupil, into the posterior chamber, and then to the, basically at that point it's going to be hitting the lens. The lens is going to be able to refract the light, and then it'll be going into the posterior cavity of the eye, that vitreous portion here. And then once it hits the retina, then the photoreceptors can be stimulated, and that'll transmit the signal to that optic nerve to the brain. Okay, it's pretty straightforward. So basically what we can see here is that the lens is going to have a certain amount of refractive ability to change light. So you guys heard the term diopter? What's a diopter? I had to look it up too. I wasn't sure, right? Because you don't use that term a lot clinically, at least if you're not like an optometrist or something. But essentially what a diopter is, if you're shining a single point of light through a lens where it's able to refract that light at least 1 meter away, right? So basically the focal point here of this light when you pass it through this lens is 1 meter away. That's 1 diopter, right? So it's basically the ability, how well you can concentrate that light. Things that have a better kind of ability to refract that light, we're going to have higher number of diopters. So the closer that you can get it to the actual lens, because it's bending that light together, the higher the number of diopters. So you can see here, like, 10 diopter is going to be able to concentrate that light very, very close to the lens itself. And our eyes typically have around a total refractive power about 59 diopters. And again, the eye's not very big, so that makes sense why you can concentrate that light very, very well for the most part. Notice here that also you're going to have different degrees of basically the way that light is going to be traveling through different substances is going to be able to change the refraction a little bit. Notice the lens here is going to have the most ability to be able to change that. And mainly it does that by using these suspensory ligaments here, okay, and also these circular fibers. Basically, these ligaments are able to kind of pull the lens apart. And you're going to normally see that when you're at a kind of a rested state, that lens is normally pretty flat for the most part, pretty flat and round, because you're going to have these ligaments are basically kind of pulling it apart, keeping it nice and stiff for the most part, right? And as things are going to be flatter, where's it going to be focusing the light? Kind of closer to it or farther away? It should be farther away, right? So as a lens is going to be flatter and more circular, it's going to be shining that light farther away. Okay. On the other hand, when you have these radial circular fibers, we'll talk about how those get constricted. That basically is going to kind of constrict in on those fibers there, those ligaments, and that's going to allow the lens to become more kind of spherical shaped. Okay. Once it becomes more spherical shape, it's going to be able to bend that light in further, and so you're going to be able to bring that light, the focal point, kind of closer into you. And so by adjusting that, we call that accommodation of the lens. Okay, so that allows us to focus on things that are far distance away or things that are very up close to us by refracting or by constricting or relaxing those circular fibers there. Okay, so I'll show you a little bit more about that in a second. Essentially, the ciliary muscle is useful for this. Again, by constricting down on it, you're going to loosen up those ligaments and allow the lens to assume its natural shape, which is a little bit more kind of spherical. And once it gets to this anterior chamber, passes the lens, it's going to be going into this posterior cavity, where again they hit the retina. It's going to be affecting the rods and cones. I'll show you kind of much more kind of blown up view of that just a little bit later. But again, based on how the lens is going to be affected, if it's going to be more constricted or more loosened up, it's going to allow you to focus on different areas of light by changing how that light kind of refracts itself into the fovea. Okay, so now if you're looking, assume this is the direction of light passing into the eye, kind of what's happening at this point. Notice here at the very back of the eye, you're going to have this pigmented layer, right? Do you guys know what this layer is for? It's highly pigmented. It's got a lot of melanin in those cells. They actually absorb a lot of light, right? That's why our eyes look black on the inside when you're just looking at them. Because they're absorbing that light, it helps to prevent further reflection of that light within the eyeball, because otherwise you have a lot of like kind of excess signaling. You wouldn't be able to really make heads or tails of what's going on. But because once the light travels through this pathway, it gets absorbed here, it doesn't really get shot back out anywhere else. Okay, so it's kind of a nice way we're able to keep that light from being reflected unnecessarily. But essentially, what we're going to be seeing here is the light's going to be traveling through. It's going to be affecting both our rods and cones. And what's the difference between a rod and a cone? Which one's for color vision? Yep, cones are for color vision, and then our rods are for? Yeah, more like black and white, kind of monochromatic vision. So we'll talk about more of those in detail. But essentially, that's where we're at. Is that cones are going to be for color vision, whereas the rods are going to be better for black and white kind of vision. And then we're also going to have, once these get stimulated, and we'll talk about the process, how that occurs, these signals are going to be transmitted both through this vertical pathway where you have these bipolar cells. Doesn't mean they're happy and sad all at the same time. Just means they're able to transmit in different directions. We also have these amacrine cells, and they finally have these ganglion cells. And that's where we get the synapses over to the optic nerve and then go to the brain at that point, right? You'll notice there's going to be a little bit of difference between when you're dealing with areas kind of lateral to the fovea versus the actual cell, how the cells are lining up, or the actual cells themselves are lining up within the actual fovea. So for instance, if you're looking at the fovea, where we mentioned that's where the most light is going to be focused, you're going to notice that there's actually just a lot of cones in that area. It's where actually the highest number of cones are going to be available. And because we're trying to absorb kind of the most light we possibly can to get the clearest picture, so it's a very kind of straight pathway through these bipolar cells to the ganglion cells. Versus here, if you're a little bit more lateral to that, still in the retina, but not really in the fovea, there's going to be a lot more rods that are available there, right? So for that monochromatic vision, but there's also going to be a lot of kind of crosstalk between a lot of these cells here. So again, when we have light being focal, being put right into the fovea, that's where the kind of focal point is. We want kind of the clear signal. We want the fastest signal we can, so we can kind of pinpoint right on that. And, if we need to make decisions on moving or whatever we have to do, we can do that. Versus on the kind of the sides, on the periphery, we don't maybe need as quite a fast transmission there. Okay, so looking at the pupil and the iris, and not the iris out there, but the iris in your eye. Again, we're going to have this pigmented epithelium here that can increase or decrease the diameter of the pupil, and this is going to be where cranial nerve number 3 comes in. This is our oculomotor nerve. And basically this can be affected by both sympathetic and parasympathetic fibers. So essentially what you can see here is when you have constriction, this is going to be a contraction of these circular muscles. That's going to be via the parasympathetic stimulation. So you guys know what neurotransmitter is going to be responsible for this? Parasympathetic. It's acetylcholine will actually be really responsible for this. This is where like your muscarinic receptors come into play. So muscarinic receptors through the parasympathetic nerve is going to allow for constriction of the pupil. Okay, this allows for less light to enter in. So when would you have this kind of constriction occur? If you're in a high light or low light situation? Yeah, if you're in a high light, right? Because you don't want to get too much light going into hitting the retina. You wouldn't be able to really make a clear picture out of it. So if you're like out in the sun, you're going to see a lot of constriction of that. Also, you can have certain medications that can do this as well. If you're activating, if you have too much acetylcholine effect there on the eyes, it's one of the things we can actually look for when I'm looking for certain overdoses. I'm looking to see, they have myotic pupils that can tell me that they may have some of that parasympathetic action actually occurring. On the other hand, though, when you want to have dilation, this is going to be regulated through the sympathetic nervous system, right? So this is mainly going to be what type of neurotransmitters do you think? It's going to be things like epinephrine, norepinephrine, things like that, which are going to be much more kind of stimulatory. Again, this is your fight or flight response. You want to be able to see as much as you can so you can run away from that bear, right? Not hit any trees in the way or something. So that's where you can see that dilation there. This would be called mydriasis, when you have that opening up the pupils to allow as much light in as possible. Okay, and of course you can be kind of anywhere in between. But if you ever see someone who's like overdosed on like amphetamines or cocaine or something like that, if you look at their pupils, they're usually very wide open, right? They have very, very large pupils. They kind of look like saucers almost because they're having so much of that sympathetic stimulation. Their pupils are just completely opened up. Okay, so again, different nervous systems responsible for either constricting or dilating that. Again, when you're kind of a dim light situation, notice here that you're going to have this sympathetic nervous system activating here. Because again, if you're in a dim light situation, you want to be able to let in as much light as possible. So you're going to see some relaxation there, those radial muscles there. Again, it's going to be through cranial nerve number 3. Versus when you're in a bright light situation, you're going to be having the parasympathetic nerves hitting this. It's going to be causing constriction of those muscle fibers, closing down the iris, so you have less light coming in those bright light situations. Okay, so cranial nerve number 3 is really responsible for this. This is kind of just showing the same thing as well. Notice there are different muscles that are actually constricting or relaxing here. With the parasympathetic nerves, these radial muscles, circular muscles that we're going to be constricting here, versus here, these radial muscles, sorry I get that term wrong, but the circular muscles are going to be through the parasympathetic nerves. That allows for closing of that. It's going to be meiosis, versus the mydriasis is happening through constricting these radial muscles, right? So that's going to be like your sympathetic nervous system. Norepinephrine is going to cause those muscles to pull apart to open up the iris. Okay, this is just kind of showing you where it's coming from, the actual portion of the brain. Here for the radial muscle aspect of it, this is going to be with the spinal cord. We see this actually being innervated from, versus this Ender-Westphal nucleus of the 3rd nerve for the parasympathetic innervation there. This part I'm not really so concerned about that you guys know, but at least know that if I had a patient who had too much norepinephrine in the system, what would happen? You'd expect them to have mydriasis due to radial muscles being affected. Those are the kind of questions I might ask. Okay, so back to the lens. After light passes through the iris, it's going to be going through the lens. Normally this is kind of an avascular component, and it's really only going to be attached by having these ciliary muscles. Again, the ligaments are going to attach to the ciliary muscles, and based on how these are constricting or relaxing, allows you to change the shape of the lens. And so those ligaments, also called zonules, you may see them referred to as well there. Hey there, I'm actually updating this slide because I actually misspoke. Thank you to your very observant classmate who was able to catch this. Essentially, what was previously on this slide, a student had asked to better clarify what was going on with pupillary constriction or dilation that occurs. Essentially, when you're looking at something like the parasympathetic nervous system, so imagine you're in a kind of rest and digest kind of state. You don't need to see a lot of light. The pupils end up constricting, cause that meiosis. That's going to be through the parasympathetic nervous system, through acetylcholine working on muscarinic receptors. That'll help to close down by constricting those circulatory muscles. And then on the flip side, if you're having the sympathetic nervous system releasing things like norepinephrine onto those radial muscles, that'll actually pull those muscles apart, pull the pupil apart, so that way you can allow more light to hit the lens and eventually the retina. So that's going to be your fight or flight kind of response there, right? So you want to see more light, you want to have a better vision, so we cause mydriasis there. Sometimes, like when you go to the eye doctor, they will dilate your pupils, and actually in a lot of cases what they end up giving you is either a drug called phenylephrine, which is very similar to norepinephrine, that will actually help to pull those radial muscles apart, or they can give you a drug called atropine, which is an anti-muscarinic drug, does the opposite effect. It's an antagonist to acetylcholine. Basically, it will sit there and block those muscarinic receptors and allow those circulatory muscles to relax. Okay, so basically that kind of explains how the pupil is going to be constricting and relaxing based on whether the parasympathetic or the sympathetic nervous system is going to be affecting that. Now, moving on, we're talking about the ciliary muscle and the lens. Again, the ciliary muscle is going to be attached to these zonules, or these kind of suspensory ligaments, and that's attached to the lens. When the ciliary muscle is loose, it's going to be pulling on those zonules. It's going to be pulling the lens, and that's going to make it very flat, and that's going to allow us to be able to focus on things that are going to be far away, right? So that's going to allow the light to be able to hit the retina, hit the lens, shine back onto the fovea, and you're going to have a pretty clear picture of that. Versus when you're trying to focus on something close up, you're going to want to bend that light more effectively in order to get it in focus on the back of the retina. There are pictures ahead of this that will end up making that more clear. But essentially, when you're trying to focus on something close, you're going to have constriction of the ciliary muscles. It's going to loosen those ligaments, or those zonules around the lens, and it's going to allow it to achieve a much more kind of natural, kind of spherical shape. And that helps to bend the light further and to get things that are close to you in focus on the back of the retina. Okay, so I just want to correct that. I said it in opposite fashion on the original slide, but again, when you are trying to focus on things far away, the ciliary muscle will be relaxed. It's going to pull that lens into a very kind of tight, flat kind of conformation, so you can focus on things far away. When you're trying to focus on something close, you're going to cause ciliary muscle constriction, which will lead to the lens having much more circular shape and allow that light to bend better onto the retina. Okay, thanks for catching that, and if you notice anything else that's incorrect, please let me know. Okay, the aqueous humor is going to be the main thing that helps to kind of keep the lens nourished, because we mentioned it's an avascular kind of substance, and we need to make sure we keep nutrients going to it and make sure we get rid of waste products. And so the aqueous humor is really important here, and it helps to fill the anterior and posterior chambers of the anterior cavity of the eye. Basically, this is kind of clear, watery liquid. It gets secreted by the ciliary bodies. You can kind of see the ciliary body right here. Secreting this fluid that will kind of flow over the lens through the iris, and then it's going to go into the canal of Schlemm, which is, again, one of my favorite body parts, I think. Basically, once it goes to the canal of Schlemm, then it'll be absorbed back into the veins and then go back into the central circulation, right? It just goes back into the blood flow. So this is really important here, because if you have anything that's blocking the, either if you're producing too much aqueous humor, or if you are not getting rid of enough of it, what happens? So your intraocular pressure is going to increase, and that can cause glaucoma. So we'll talk a lot about that, at least in pharm when we get to the eye section. But essentially, if you have too much ciliary aqueous humor being produced here, or if you have not enough of it being released, and that could be due to certain angle closures and things like that, which we'll see a little bit later on. That can lead to intraocular pressure increasing, lead to glaucoma, which can eventually lead to that pressure, especially on the retina, can lead to nerve damage over time, lead to blindness, and so it's no good. So again, the aqueous humor is not anything to laugh about. Okay. Just seeing if you're listening. Okay. Again, just another picture kind of showing the ciliary body, how it's producing the humor, coming through here over the iris and then into that canal Schlemm where it can be reabsorbed into the central circulation. The way this is produced is through these trabeculae, essentially, where you're going to be having this aqueous humor that's being produced, usually through like aquaporins and whatnot. So we kind of talked about those being utilized to help transmit water through cell membranes and things like that. So this can be utilized to help produce it. So we can have drugs that can either shut down the production of aqueous humor. We can have drugs that help to increase the clearance of it. We'll see that when we get to the pharmacology for that. But it's essential. We have constant recycling of this aqueous humor. If we don't, then that's where we have pressure problems and can lead to glaucoma, right? Because any pressure that builds up here is going to transmit back into the actual vitreous humor as well and transmit back to the nerve. Okay, we don't want that. Okay, so light refraction. So this is going to be light when it passes from one medium to another with a different density, and it's going to lead for it to bend, right? So anyone uses glasses in here? See if you pair it, right? This is going to be assistive refraction of that light right before it hits the lens. So essentially what we're seeing here is that light's going to be bending, and we want to see how it bends and how we can affect that and how we can focus on different things based on that accommodation. So when we have that ciliary muscle constricting down in the lens to allow it to achieve a more spherical shape, or it relax and to pull it apart, that's called accommodation, right? And so you can see lots of things that may affect accommodation, not to mention drugs can actually affect that as well. So you can sometimes have patients have impaired ability to accommodate based on certain drugs that they're taking. We'll look at why that is just a little bit. So essentially, when you have light coming in to the lens, notice here that it's going to be flipped upside down and also left to right, right? So I always think that's still one of the most fascinating things to me, is that we can view light, and even though it's being flipped upside down, left to right, we can still, our brain is smart enough to at least put it back the right way, right? This is one of the things to always note with this, is that we're always having to reorient these pictures in our mind, because it's coming in through the lens in that orientation. But essentially, you can see this here. We notice like the bicycle rider, his light, when it passes through the lens, gets flipped. Okay, so he's going to be actually appearing on the back of the retina as a upside down, going the opposite direction, essentially. Again, this baseball player is kind of showing the same thing, where he's being flipped over left to right and upside down. Okay. So when we have this accommodation, based on where the thing, our focal point is, where we're trying to focus and get the clearest picture on, whether it be far away or close up, that's going to be changing the accommodation of that lens so we can refract that light appropriately to make sure we're getting the clearest picture that we can. And so accommodation is that ability of the lens to keep an object focused on the retina as the distance between the eye and the object moves, right? So I can move from the front of the room all the way to the back, and I can look at one single point, whether it be the clock or whatever, or one of you guys, and my lens will be able to accommodate the whole way, so I can always keep focused on one of you guys, right? So contraction of that ciliary muscle is going to allow for that ligaments to relax, so it's closing in around the ligaments. It's going to loosen that up, and the lens is going to thicken and round, and that's good for close or near vision. Okay, it's going to allow us to be able to see things a little bit closer, and then relaxation of those muscles. We're going to have the muscles actually pull apart on those ligaments, and it's going to have the lens have a thin and flatten, and it's going to be better for kind of far or distant vision. Okay. And so the ability for us to actually look at accommodation, we can use these eye charts, and is able to determine how well a person's vision is at being able to accommodate on various lines of this. So for instance, looking at near points of vision, we're looking at the nears, the minimum distance from the eyes an object can be put into focus. At a certain point, things get too close, and we're not able to accommodate anymore and be able to see any more clearly. And then look at the sharpness of vision is going to depend on that resolving power, or the ability for us to determine, kind of distinguish between two closely spaced objects together. Okay. Then normally we're going to be detecting this with a chart that normally the person will be standing 20 feet away from, and this is where we get the idea of like 20/20 vision, right? So if you're able to stand 20 feet away from this and you're able to read line 8, then that would say, okay, you have 20/20 vision. So you have exactly the kind of refractive ability to determine those what those letters are from that distance. Otherwise, if you're not able to, you'd have poor ability to refract unless you're going to have, say, 20/40 vision or 20/50 vision. So that's kind of where those numbers end up coming from. Again, we want to constrict this. We're going to relax these muscles. That's going to tighten up on those ligaments, and it's going to flatten out the disc. Yes, ma'am.
So I have a question about the
Yep.
How many do they have to get right before they begin?
Usually you end up kind of going from top to bottom. So you'd read like the top line, and you kind of keep going down until you can't read them anymore. At least that's how I've always done it. Not that I've given a lot of exams, but at least people who have ever given it to me, like you start at the top line, you kind of go down until you can't read them anymore, and then whatever that last line they were able to read successfully was, that was kind of where you're calling it. Yeah, so if the last line they could read appropriately was 20/40, and you say that, yeah, they had 20/40 vision. Right, and you can do it for each individual eye as well. Right, and you guys will probably cover that as well in your physical exam course and all that.
No, he tells us to like the smallest line you can read, but I know that people often get like 1 or 2 wrong.
Mm-hmm.
Does that make it back up or?
I'm not sure. That'd be hard to say. Half right? Okay, that sounds pretty good. Yeah, like I said, so that's one of the things you guys will notice, at least about me, being a pharmacist. Like, we got a lot of different training on a lot of this stuff than, like, so, like, I didn't really cover eye charts a lot when I was in school, right? So a lot of this stuff, you know, clinical practice may differ from what I've ever been experienced to or something like that. So that's why if you have a different teacher who says something different, obviously that's what they're testing on, so obviously listen to that. But we can also have differing opinions on things. It doesn't mean one's right or one's wrong. Someone just may have more experience with something than I do, or I may have more experience with something than they do, and vice versa. So you learn there's a lot of gray with medicine and all that. On that one, I'm just wrong, so that's okay. I'm okay with that. So anyway, so if you would like to be able to bend that light even more, you'd want to have a thicker lens essentially, and so by bending that you can cause constriction of those ciliary muscles, and that's going to cause the lens to slacken up, the ligaments slacken up, and that allows the more spherical shape to develop there. Okay. So looking at various types of vision, I'm actually what time is it? I'm actually going to cut it there. I will record the rest of this. You guys will view this before the review on Tuesday. I think it's Tuesday, right? It's our next class session. And then the test will be Friday. Is everyone okay with that? Does anyone want to mutiny before then? Any questions I can answer for you before then? Okay, I'll see you guys next time.